Good morning, I'm Dr. Don Peacock. This morning we're going to talk about utilizing amniotic stem cells for heel pain. We're going to go over a case where a patient's had heel pain for more than 1 year, and he's had other treatments including orthotics, previous cortisone shots, and the normal conservative care. He is a patient that cannot be off work for an invasive procedure. This is a minimally invasive procedure, and it's a procedure where I'm using and other people are using around the country. In my opinion, the advancement of amniotic stem cells is one of the best advancements in podiatric surgery. I've used this successfully with tibialis posterior tendon ruptures, utilizing that along with the hypocure, and I've also utilized this with posterior heel pain with a lot of success, and now starting to use it with plantar fascial problems. Now with plantar fasciitis, we know that it may not be inflammation in the fascial band as previous studies have shown. So a better term is plantar fasciopathy. One of the things we use to evaluate heel pain is the ultrasound. And we have 3 zones of measurement. Our most distal measurement we call zone A. And then there's zone B, which is where the bone spur is at basically in most patients, or the medial tubercle. And also we look at zone C, which is the calcaneus, and we basically measure the hypoechoic feedback on our ultrasound. These measurements are important, and there's actually a way to stage this. Dr. Barrett has a nice way to stage this. And basically when patients have more than 6.5 measurement, you're looking at more aggressive procedures needed to get rid of pain. This patient falls in sort of an intermediate category, where most of his pain was located is in the medial tubercle area and just distal this where common plantar fascial problems are noted. He measured 5.7 here, which is sort of in the range of where he's obviously had the issue for a while, but may not be a surgical candidate. Now the procedure we use, basically we use amniotic stem cells. Here's a little view of that where we're getting prepared. Now we do utilize an 18 gauge needle so that we can see this under the ultrasound. They do make needles that are made for ultrasound, but you can see an 18 gauge needle fairly well under the ultrasound, and that's just a basic cheap needle. Some of the ultrasound needles are quite expensive. Now this is done under a tourniquet, and we've already performed a tibialis posterior nerve block on the patient so that the patient has anesthesia and we're not hurting the patient. When we advance the 18 gauge needle in, we're going to look at both a transverse and a longitudinal view of our needle so that we get an exact placement into the area where we're trying to inject our amniotic stem cells. So you can see this is our longitudinal view, and if you look at the ultrasound in this view, you can see this little white line here right at our fascial band. This is our longitudinal view here. That is our 18 gauge needle. You can actually move this around so you can kind of tell where your needle's at and you get a good view of this. Once we have this in place, we then make several passes through this area to basically open up the fascial band. So we're going to do 4 or 5 passes to make small little channels in the fascial band so that when we inject our amniotic tissue fluid, it'll go into these areas and help with our regeneration of the plantar fascial band. Once we're in an exact location, then we basically at this point we'll remove the syringe. This is another view here. We see our exact location. This is our other view, and showing this is where our needle is at right here in our picture here. So we're going to basically determine through 2 views exactly where we need to inject the amniotic stem cells. Once that's in the exact position, we then remove the syringe and replace that with our amniotic tissue fluid syringe. This is our transverse view showing our needle here exactly in the area of hypoechoic feedback where we want to inject our fluid. Once we have our passes through the fascial band and we've now changed to our amniotic fluid, we will inject this in the exact position where we determined this to be by utilizing the ultrasound. And you can see our final view here is the ultrasound. This is our longitudinal view, You can see this looks like we've actually increased the hypoechoic area here. This is actually our stem cell injection here. This is where amniotic fluid is at. Now this procedure is fairly quick. It's done under the tourniquet. We basically use a band-aid to go over the initial dressing, then a little compressive dressing. The patient can walk on this in about 30 minutes or so. And the patient can go back to work really quick with this, usually within a few days. Some patients have a little flare of pain. Now this entire procedure was done minimally invasive, and basically if you see our tourniquet here, it took us about 8 minutes to do this. So this can be done fairly quickly, utilizing your guided ultrasound there. So just a little minimally invasive way to perform correction of plantar fasciopathy in patients, utilizing guided ultrasound techniques and utilizing minimally invasive techniques to get patients back to work quicker. And this has been very successful in our practice with other deformities we treated, including other patients we've done with plantar fasciitis. The actual medications for this and the actual amniotic stem cells are going down in price, and so it's getting a little easier for patients to purchase this, and it keeps them from being out of work. It's a very quick way to get rid of heel pain, and in my opinion, this amniotic stem cell advancement is one of the best advancements in podiatry right now, and it's utilized in different deformities, and plantar fasciitis being almost custom made for it in certain patients. Now this patient does have a rigid rear foot and a flexible forefoot, so these types of patients do well with injections. I would not recommend this in patients who have flexible rear foot and flexible forefoot, because the etiology is going to be more biomechanical and not overuse, and they'll need to be treated in a different way. So I just want to show you this little technique and show you how I'm doing it, and other people are doing it the same way. Little variations of this technique too. Dr. Barrett has a great little technique, a minimally invasive way, where he actually scrapes the fascial band. This is in patients that have a little thicker fascial band than what we're showing you here, and that works very well. It's a very good procedure as well. Anyway, I wanted to just show you this, and I appreciate you watching.